Hello, I am here to give you some surgery tips for your rotation. So a typical day will involve you coming in anywhere between 5 to 5:30, depending on what service you're on. And you'll usually pre-round on 1 to 2 cases, and followed by an M&M conference sometime around 7 a.m. And M&M refers to mortality and morbidity conferences, in which they discuss cases where there was a complication that was unexpected or shouldn't have happened. And then surgeries are typically around 8:30, so there is a little wiggle room after M&M conference and surgeries to get a coffee or get a little breakfast. You may have elective choices in your rotation, so you may be able to select subspecialties within surgery. I kind of show you some here. And I did urology surgery, and I had a blast on urology service, which is what I was originally interested in. So I definitely recommend checking that out if you're inclined. And so what you should be doing on your rotation, prepping for pre-rounds, you want to take note of what the surgery that the patient had in the chart. So I typically wrote that at the very top, and then also noted how many days post-op they were. Quickly look and check the vitals and note the vitals. Any relevant labs, especially CBCs, and you want to specifically highlight anything that's abnormal so that you can recall it when you're presenting it. And you want to pay close attention to the white blood cell count and temperature of the patient, because it's typically signs of infection if you have fever and elevated white blood cell count from what they normally have. So those are some things to keep an eye out. And then somewhere in the EMR, you should find a tab for something called ins and outs, which is what you will also present, which is kind of their excretion, their eating and drinking, and also how much they're excreting. That will be listed for you, so you'd want to note that. And in the outs in particular, note the number of bowel movements they have if they had it. And then also important to note is pain control medication. So what things are they on to control their pain post-op, and the amount of that as well. So when you're seeing the patient, you want to ask a few key things. You want to ask about pain levels, how are they doing in general, and also noting bowel movements that they've had, or if they've been passing gas. Those are good signs that their bowels are working, so you want to check in on that. And then you also want to get a sense of how active they are. Like, are they sitting up and getting up in the chair, or are they walking now? You can also get a sense too on physical therapy notes of where they're at, but it's also good to ask the patients themselves what they're experiencing. And then also if they noted subjective fevers and chills. And then for exam, you want to check out your heart, lungs, and skin. And you can also even check the surgical site as well, or if they have any wounds as well. But you only want to check, usually the surgical sites are bandaged or covered. And I would only check those if your resident has already been checking them on your rounds, just so you don't you don't prematurely take off their bandages. But if they have been checking them, then you might want to also check them in the morning just to make sure there's no erythema around the surgical site. All right, and then supplies. One thing you can be helpful in is grabbing some supplies on your pre-round time, so that when your residents and attending come, then you'll be prepared to help. And things to grab are, they call these abdominal pads. I think they usually refer to them as APDs, as an acronym. But these are usually found within the patient rooms in the little side closet or you can find them behind the nursing station. And then the other thing you would want to grab is, they call these acrylics. It's basically like a long gauze that sometimes they'll put in the wound, this whole packet in there. I would keep a packet of this in case your resident wants to repack a wound. And then some tape. So this surgical tape is handy to have in your pocket in case they need it. And additionally, carry I used to usually grab a pair of gloves for the resident to hand over when it was time to examine, so they didn't have to awkwardly go to a strange place to pick up gloves, because sometimes it's not conveniently located or it's missing from the room. So I would grab your resident a pair of gloves for exams. And then to prep for your OR cases, I would in general read the day prior about the surgery that you will be participating in. And you might also want to look up videos too of what the process looks for that, so you have a general sense of what's going on. And then in general, you want to be in the OR before the surgery case starts. So this is very critical, because you will want to introduce yourself to the OR nurses so they're aware that you're there. There's sometimes a board where you can write your name on the board. Sometimes there's a section for students that you can write. You also want to give your ID card to the nurse sitting at the computer desk, because they need to document everyone that's in the room. And so this is just easy to do before the surgery case starts. And then in the OR room, there's usually a section of supplies for gloves. And there you want to get your gloves. And you can also ask your resident to grab their gloves as well. So you want to know their size. And you might have probably already done that during orientation. I found in general ladies have anywhere from like 6 to 7 range, just as a reference point. And then you can also ask the OR nurse. There's usually a scrub nurse sitting by a drape table where you can open and drop sterile gloves on the sterile table. You kind of carefully, without touching the gloves inside, peel it open and let it fall onto the sterile table. You can also observe how the other nurses do it just to get the technique right. But you always want to ask the nurse at the sterile table if it's okay to drop your gloves, because they usually prep and have the surgeon's gloves ready to go, but they might not have yours ready. And when in doubt, you can ask the other nurses that you set your gloves to the side in case you're not comfortable doing that, or they might tell you themselves to set them in a specific location so that they can handle that. And in general, from my general experience in the surgery rotation is that they will usually allow you to close any ports at the end of the case. So that is your moment to shine. And in particular, you want to watch lots of videos about how to do subcuticular suturing. So this is the one suture I used like 98% of the time. I learned how to throw knots, like both two-handed and one-handed, but I think I can only recall one time where I was asked to tie a knot. But I was asked to close ports with subcuticular suturing the majority of the time. And then how to be helpful in the OR. If you're not going to scrub in the case, some of these are more helpful than the others. And sometimes you might actually not want to scrub in, depending on what the surgery you're observing is. If it's a surgery where the opening is super tiny, sometimes laparoscopic ones can be like that, or neurosurgical ones, ENT ones. Sometimes it's just nice to sit and watch the video that's happening. They usually have like a screen of what's happening, and that's easier sometimes to visualize. From afar, you can grab a seat and watch what's happening. But obviously, if you have the opportunity to scrub in, then do that. And so while in the OR, you can help the nurses by tying their gowns. If you're the first person in the OR room, as you should be, there might not be a scrub nurse gowned already, so you can help her Velcro the tab in the back and help her tie the back of her gown. You can also ask the nurses if they need an extra gown for you, so you can put on the table for them. And again, also get gloves too. Other things that you can do, or what you probably will do to be helpful, is you push the buttons to get the doors open for the patient's beds to come in. You can help wheel in patients to the OR. And then once the patient's on the surgery table, you will most likely be asked to bring the bed out into the hallway. And usually there's a designated place for the beds right outside the door. So that's kind of what you will probably be expected to do. There's also placed on the table usually are pneumatic devices that are turned on during the surgery. So they look like this. Probably seen them in the hospital. And so those you can help by placing them onto the patient's legs and hooking them up to the machine. So they're usually unhooked. And then usually at the bottom of the surgical table is this machine that lets in air into the pneumatic devices to compress the legs. And so you'll just hook up this tubing to this white component on both legs. And then this device is usually at the bottom of the bed, and just hit this blue start button. So that's how that works. And then another thing to both help yourself and the rest of your team, you can also get stools if you are on the shorter end of height. You may need it, and your resident might need it as well, so you can ask ahead of time. And usually they raise the height to the level of the surgeon. So if your surgeon's really tall, you'll probably need 1 to 2 stools depending on what's happening. So then once the patient will be under anesthesia, you can help to strap in patients with these and secure them to the bed. They're usually one end's hanging off the side, so it's there. But if not, you can also help by helping to find it and bring it over to the bed. Once they're asleep, they usually place the Foley. Sometimes the surgeons will do it themselves, but this is an opportunity where you can help and learn how to place Foleys. And then after this point, once the Foley is in, usually you can prep to scrub in. All right, so once you're scrubbed in, ready to go, that's a whole nother process as well. Usually the surgeons and residents will be gowned up first, and you're usually the last to be gowned up. So they may be focusing on getting everything ready, so you may be waiting there with your hands out for a bit, but they should usually help you. And if you've never scrubbed in before, just let the nurses know ahead of time, so that they are a bit extra patient with you and can walk you through it. I would look up some videos on how to scrub in, and your rotation probably will give you a little run through of how that works. Once you're scrubbed in, you can also help there by placing the sterile coverings on the overhead lights. They kind of look like a funnel, but that's something you can easily help in and just screw it in. Kind of observe what the other residents are doing. Some of them will ask you to suction the bovie smoke, so that's this kind of cautery tool, and it leaves this smoke that smells really bad. Some surgeons will want you to suction, others will not. Just observe to see what the preference is, or you can ask as well. And then be ready with the suction to also suction body fluids, or blood that's accumulating that's in the way. And then you can also help by moving some bloody sponges away from the field towards the OR nurse. That scrub nurse will like pull them away and put them on the table. And then also be ready to cut some sutures. So sometimes the scrub nurse will preemptively hand one to you, have it ready to cut when the surgeon starts tying and throwing knots. And that's when you know that you're probably going to cut some sutures. So just be ready to do that. And then again, also be prepared at the very end. The case, the surgeon will usually walk off and leave the closing of the ports to the fellows and other residents. And that's your time to be helpful and help close off some of those ports. All right, and at the end of the case, some things that you will be helping out on is helping remove the drapes from the patient. You can also help to connect these JP drains. These drains the fluids from the internal body cavity. What you do with this is the resident usually will place these inside, but you can connect. This bulb is usually sometimes separate from the tubing, and or you can, if you squeeze this, it creates this like negative pressure so that the fluids are coming out into the bulb. So you can do that once it's secured. Usually the residents will secure with some knots, so be ready to also cut during this time. And then other things to do are to use wet towels to wipe off any of the excess blood, any residue, sticky residue from the drapes from the patient body. So you can dab at those excess residues. And then you always want to see if it's time to bring the patient bed in. Always ask permission before doing this because it might not be the time to do that. And once you bring the patient bed in, you can also grab the body, the slider board. This is to help move the patient from surgical table back onto the bed. So things to help out for the team moving the patient are you'll find outside the OR these metallic refrigerator-looking structures. Inside there'll be warm towels. So you want to grab maybe 2 to 3 of these warm towels and then put on the patient bed to be ready. One of these towels, once you observe it long enough, you can also help prep the slider board. I think different facilities have different protocols for this, but you can also observe what they do a couple of times and help with that. And in my experience, we had one of these blankets folded over the body board, and I usually prep that for the nurses. And then the rest of the blankets are to help keep the patient warm once they're moved over to the bed. Just right before they're going to move the patient, you make sure to disconnect those pneumatic socks that you plugged in the very beginning prior to moving the patient. And then you also will start to unhook them. There, if you recall, there was a black kind of body strap. Once they're ready to be moved over, you can start to unhook that. But be sure to remain close to the bed if you unhook a side, just to make sure the patient does not fall. And then you will also probably be asked to help move the patient to their bed. And the easiest role and most common role for a medical student is to move the feet. So you'll go towards the end of the feet and lift up the 2 legs and move to the patient bed. So that's the easiest role for a medical student to do. And at the end of the case, you'll also wheel the patient with the residents to the PACU. Usually, I believe, also followed by anesthesiology team as well. So they'll usually report and get vitals from them as well. During this time also, and anytime during the OR, if you want to learn something here and there, you can also talk to the anesthesiology team They're great. They're great at teaching. You can also observe what they do as well and learn from them. And then what to read. So this is probably the best book I've come across on any of the rotations, the most high yield book in my mind. And this is by DeViriglio, Surgery. It's just very concise and the information is just easy to digest. So I recommend getting your info from this book. It's probably available. It's available online, and I carried around a printed copy of some chapters in my pocket during outpatient surgical follow-up visits, just to have on handy to study if you have some downtime. So that's it for tips for your surgery rotation. I hope this was helpful. Thanks for listening.